Welcome, everybody. Good morning, good afternoon, good evening, and I wouldn't say good night right now, but really honestly, let's jump into this episode two, where we are actually going to be talking about a very specific and special topic, MIGS as a refractive cataract surgeon. But before we do this, before we jump into the episode, let me explain to you really how all this works. Each episode of the Rising Star series will feature one rising star and surround them with three celebrity panelists. Now, guys, celebrities, these are people who really have we've cherished and loved over the years because of the job that they do in the field of ophthalmology. And we honestly are thankful to having them on board. The Rising Star series is a very, very interactive series. So as any audience member out there, please throw in your questions into the YouTube question window, and we'll happy to, as moderators, pass this on to the panel and the speakers and get some answers, get some pearls out there. We're live on risingeyestars.com website and on our YouTube channel on Rising Stars in Ophthalmology. The reruns obviously can be watched, as this is a very, very big global event. The reruns can be watched on our website, that is risingeyestars.com. Also look out for the social media, Facebook, Twitter, LinkedIn, Instagram, wherever we release all these educational tips and snippets from all our episodes. I'd really like to thank all of you guys for personally tuning in to this live episode, and thank all the sponsors to making this happen. And now, to do the honors of introducing our celebrity panels and our rising star, let's get Jen Lowe on board to help introduce. Jen has been an extremely backbone to this whole event. So thank you, Jen, for being part of and moderating this event with me.
Thank you so much, Ashwin. As always, it's a pleasure to co-moderate with you and to share the stage with our rising star and celebrity panelists. Before I introduce our speakers tonight, I did want to thank our sponsors for season 3. And without our sponsors, it would be impossible to run this season. So a heartfelt thanks to everyone for their support. I'd like to thank Allergan and AbbVie Company, Elcon, Vices Therapeutics, Dompe, Avellino, Young MD Connect, Sun Ophthalmics, and Tarsus for their generous sponsorship to help us run our program. Thank you. And now I would like to share my screen and go ahead and introduce one second here. I'd like to introduce our episode for tonight. As Ashwin mentioned, this is episode 2 of season 3. And Dr. Deborah Ristvedt is going to be our rising star tonight. And our celebrity panelists, I will be introducing as well in one moment. So To begin, we have Dr. Jay Parekh, fondly known to us as Dr. J, and he did college at Boston University, medical school at Boston University as well, and his residency, he did a combined program at Boston University as well. He did his fellowship at New York Eye and Ear, and he also did an MBA at Duke. His current position is clinical associate professor at New York Eye and Ear, as well as he's the CEO of Eye Care Consultants of New Jersey. And he, as you can see in this really cute photo, he drives around a pretty cool car with some cuties in the background. He does, which I'm sure Jay can tell us a little more about. Also, a fun fact about Jay is that Jay means victory in Sanskrit, and he's also the team doctor, also known as Coach K in Dubai and China, and he's an ambassador for the basketball trip. So Jay, can you just give a few brief words about your fun facts or the little cute dogs in the background there?
Yeah, during COVID, there's no doubt that we all got depressed. And the second dog there on the right is a Bichon Frise. We got him from South Carolina. So truly did a lot for us in terms of euphoria and just helping out in the house. But no, we love dogs. We're empty nesters. And I'm thrilled to be with you, Jen, and Ashwin and Billy and everyone tonight. This wonderful discussion on MIGS and how it falls in the cornea. So thank you for having me.
Of course. Thank you for being here. Next up, we have Dr. Lisa Feulner, who went to college at Case Western Reserve, medical school at University of Rochester, and residency at University of Minnesota. And not only does she have an MD, but she also has a PhD in molecular neuroscience, which she achieved at the University of Rochester. And she's the founder and managing partner of Advanced Eye Care and Aesthetics. She also is an amazing ballroom dancer. And I wanted to show the actual video of her ballroom dancing, but I wasn't quite able to put it on. But I'd like you to share a few words, if you will, Lisa, about your fun fact, as well as any experience you'd like to share.
So I sort of got conned into doing ballroom dancing. My parents were actually ballroom dancers. And there was a fundraiser in our town to raise money for a Center for the Arts. And they needed sort of local celebrities, which I think we all are in our own hometown here. And so they asked me to be one of the celebrity dancers, much like tonight, being a celebrity panelist. And we had to raise money for our dance. And I don't think you can see that outfit, but my partner, he picks the outfit based on, who he thinks you are when you walk in the room the first time he meets you. And so he decided that I had to do a Latin dance. So we did a rumba sort of mixed dance. And he brought out my outfit and said, "This is what you're going to wear." And I said, "Where's the rest of it?" You can't actually see it, but there's not a lot to that. And it was a little frightening at times. And I was most worried during the show that my son was going to freak out because it's a very sort of physical and romantic dance. And it was actually my husband that had the hardest time watching me dance with this guy that wasn't him. And since then, since I did this very first dance, I've really enjoyed doing ballroom dancing. I just absolutely love it. Actually, I thought Latin dancing would be my thing, but waltzing is really so beautiful. It's my favorite.
That's very cool. You've inspired me. I think you might have to take
so
a
much fun. And it's fun to do with your partner. You
Yeah.
go to these parties and there's these people doing lovely dances and you're just sort of rocking back and forth with your spouse. Just, people notice good dancers, so it's fun.
All right. I'm going to have to check that out. I'll rope Bill into something, maybe a ballroom dancing class. All right. So last but not least, we have Dr. Mark Lobanoff. He went to college at Duke University, medical school at University of Michigan, residency at Emory, and a fellowship at University of Minnesota. He's a currently the CEO of 3 different companies and founder. So CEO and founder of Ovo LASIK and Lens. He's also the CEO and developer of Forcities and the CEO of Lochan, I think, which he told us in Sanskrit. You'll have to tell us, actually, Dr. Lobanoff. I forget what you told us it meant. What did it mean again? I know it was Sanskrit.
So it's Sanskrit for vision, or the ability to see.
Okay, I should have remembered that.
Yeah.
All right, thank you. And your fun fact is that you like to restore and race vintage snowmobiles.
That's right. So I moved to Minnesota a number of years ago and quickly realized that winter lasts about 9 months of the year and needed to find something to occupy my time, and fell into this quirky hobby of restoring these old racing snowmobiles from the early 70s and racing them on the lakes that we have here in Minnesota.
That is amazing. That's really cool. All right. Okay. Well, now I get to introduce, I'm very lucky, our rising star and one of my friends, Dr. Deborah Ristvedt. She also is in Minnesota. Actually, we've had a lot of people represent Minnesota today on this episode. I love it. So college, she did at Westmont College in Santa Barbara, medical school at Des Moines University, residency, Michigan State University, and her current position, she is the leader at Vance Thompson Vision in Alexandria, Minnesota. And not only that, she's a 3rd-generation ophthalmologist at that practice. So I can't wait to hear more about that. She, fun fact, studied abroad in Sri Lanka, Samoa, and New Zealand. And next up, I have some photos that I'll let Deb describe. So the floor is yours.
Wow. I am just so humbled and honored to be here. And I just cannot thank Jen and Ashvin and Bill and Laura enough for the incredible amount of work they put into this to really educate all of us. I've learned so much through Rising Stars seasons 1 and 2, and I'm super, super excited to put our celebrity panelists on the spot tonight. So with that being said, I am a 3rd-generation ophthalmologist, and I wouldn't be standing here without them. My first trip on a medical mission to Sierra Leone, West Africa, was after my first year of medical school with my grandpa, my dad, and my sister. And that's where I really found that, I had this heart for ophthalmology, and that's what I wanted to do as a career. I had great mentors growing up, and they always taught me to be pioneers and, to do the right thing and be kind. And that's my dad on the right in surgery with me. He actually came out of retirement to help me with research. And so he's right alongside of me. We have a blast together, and I know Bill loves his dad with him too. And then, nothing would be complete if I didn't honor my grandpa. Unfortunately, he passed away in June, just shy of his 101st birthday, and he passed away peacefully, but he was the award recipient of the Chang Humanitarian Award. And man, a humanitarian he was, serving over 13 countries over his career, mostly in Africa, over an 18-year stint full time. So again, I couldn't be here without them.
Wow, that's beautiful. I had no idea he won the Chang Humanitarian Award. That's really such an honor, and that's amazing. All right.
Oh, you talked about Napa, Lisa, and this is us in Napa just in June. This is my work family. I call them my work brothers. I have been with Vance Thompson Vision for 4 years, and I have never met such kind, humble surgeons that do so much for our field. And I am just so honored to work alongside them every day. You can see that we span now Minnesota, North Dakota, South Dakota, Omaha, Nebraska, and Montana. And we just keep growing. And it's really been a partnership that's pushed me in my career. They've encouraged me along the way, and I couldn't thank them enough for being alongside me.
Amazing. All right. And your loves.
Yeah, last but not least, these are my people. I have a husband, Eric, of 17 years. I love him so much. He's kind of a high school sweetheart, but I dumped him because I had to go to diving camp, and then we ended up getting back together later in life. But we really enjoyed being in our hometown in Alexandria, Minnesota, raising 3 beautiful children, Sophie, who's 11, Blake, who is 9, and Anders, who is 6. He's kind of spicy. In the summertime, we are constantly out on the lake surfing, wake surfing, traveling. And, like Mark said, as a Minnesotan, you have to endure the winters. And so we build an ice skating rink every year. Our kids are really involved in hockey. So I think Dr. J may be a hockey fan, if I remember correctly. Maybe not, but I think you are. And then in my spare time, I like to paint. And so I painted a lot during COVID when I couldn't do surgery. And so some of these paintings are from that time. But again, love my family, love being in my hometown.
That's awesome. I had no idea you painted those paintings. That's so cool.
And
Really
Jen,
cool.
that picture in the bottom left of us whitewater rafting, that's what we're going to do with Danny next summer.
I know. I can't wait. I'll be so excited. Yeah, it'll be really fun. All right. So I don't want to delay. I think this is the last slide. So I don't want to delay your amazing talk a minute longer. So podium is yours now. Take it away.
All righty. So thanks again, you guys. And I think it's going to be a really, really fun evening talking all things MIGS as a refractive cataract surgeon. I'm a 3rd-generation comprehensive ophthalmologist. So why am I talking glaucoma? And as I was thinking about how to put this talk together, kind of a mindset came up, and that's how we titled this talk, How a Proactive Mindset Improves Quality of Care, because that's what we owe to our patient is quality of care. And when I think about how I approach each individual patient, it really comes down to looking at their quality of life and really pushing myself to do the best that I can do for them. And so I'm going to go to the next slide. Let's see. And it is not working. Sorry,
Hit
guys.
the little arrow at the bottom. Sometimes it's like I like the little arrow at the bottom left. Sometimes I find it.
Oh, there we go.
Yeah.
All right. You are so you said you weren't technologically savvy. I think
It's
so,
only
Jen.
because of all the mistakes I've made. That's why I know
Yeah,
this.
thanks.
I've done it myself.
So, I've always thought as an ophthalmologist, we have a great responsibility as cataracts are the #1 leading cause of blindness worldwide. And as glaucoma is the 2nd cause of blindness worldwide, this is a huge cause of disability, and it really impacts the quality of life in our patients. And so as an anterior segment surgeon, they all kind of blend together for me. And that's become more so in the last 10 years than ever before, that we're looking at not only cataracts, but also glaucoma, dry eye, and beyond, and looking at quality of life and saying, okay, how is it affecting our patients and what can I do to help them? And even a 2-line decrease in visual acuity can cause driving difficulty. You talk about COVID and isolation. Well, even these types of conditions can cause anxiety, depression, dependency on family members for basic needs. And then when you think about glaucoma, the diagnosis itself is very scary. And some patients have already lost vision by the time that they come into your office, and they can't get that back. And then you start to talk to them about the treatment options, knowing that their vision won't be restored, and it can be very daunting. And so my first question is to Dr. Feulner. I heard you say something the other night about dry eye and how it was so critical that we think about that when we're treating glaucoma, when we're doing cataract surgery. And beyond that, how has focusing on quality of life impacted how you treat your patients?
I think, and I talk to people when I give, dinner talks around the country, that we have a duty to treat the whole person. And in our case, the whole eye. We don't get to pick and choose what part we're going to address. So as cataract surgeons, we're always concerned about the ocular surface. We don't have an option to ignore it. And we forget sometimes the burden that we put on patients to improve their ocular surface prior to surgery. It's very intense. We ask them to do a lot. And if you treat glaucoma, you're, inherently creating, dry eye. So we burden them with the task of taking medications, follow up, taking various tests in our office. We create a disease, then we ask them to fix that disease by doing a whole nother series of things. And so the burden on the patient is huge. And, we have to be mindful of that. And I think your topic tonight is going to be very pertinent to help reduce that burden and the impact that our own therapies have on these patients. And so I'm always very mindful of that when I'm making decisions about what I'm asking my patients to do. And if you have older family members, you know what it's like for them. And you hear them say, all I do is go to the doctor and I have to have all these lists and things to remind me of all the different things that I have to do. And we forget as ophthalmologists that we're just one of the many physicians that these people see. So I think being mindful of the burden that we create and the burden that we cause on our patients, it should be at the forefront of our mind always.
That was just absolutely beautiful. And Lisa, what you're kind of talking about is individualized care. We're trying as eye care providers to provide simple, sustainable, and scalable treatment options for our patients, despite what specialty we may be focused on. And, last month, Dr. Schaefer gave a wonderful talk on the patient experience. And in our charting, we have this acronym called FORD. It stands for Family, Occupation, Recreation, and Dreams. And so not only do we want to get to know our patients, but we also want to know their lifestyle. And so we can really dictate how we want to treat this patient or what we want to recommend. We love focusing on technology that may take burden off of our patients. And so I've really pushed myself to learn new techniques, to learn new technology, and invest in technology for our patients. And so this kind of goes along with our proactive mindset, right? Where we don't want to be complacent in what we do. We need to continue to grow, do the right thing, invest in technology that's going to help our patients even more, and really be comprehensive in our approach to what we do. And so when we look at surgery in specific, the most common cause of fear and anxiety is loss of vision. And then it's followed by pain during the operation, its outcome, fear of the operation itself. And so this is tying exactly where we're going when we're talking about a certain procedure in pre-op areas or in the clinic as to how they're going to do. And so it's really, really in focus that we're important that we're focusing on quality of care. And so Dr. Lobanoff, in looking at quality of life and quality of care, what are you doing differently when it comes to cataract surgery and going to the operating room than maybe before?
So that's a great question. And I've really changed my approach in cataract surgery over the last 2-3 years. Before I might talk about certain lenses, the cataract itself, and now every single cataract preoperative visit begins with the patient. What are they doing? What is their life? What are, just like you said before, what are their hobbies? What really is their passion? And determining what quality of vision they want after surgery. And we have so many amazing tools at our fingertips now. We've got these trifocal lenses that can restore near, mid-range, far. We've got light adaptable lenses. We've got EDOF lenses, mix and match strategies. And it can be overwhelming. And so rather than dive in and talk about the individual lenses, we talk about the patient's lifestyle and their quality of life and what do they want out of this. And then that starts to lead the discussion towards perhaps a certain method or surgery that's going to achieve that for them. But it is so, so important to look at the quality of life. And then your last slide, it really hits home. All those things that patients are worried about, is this going to hurt? I immediately say this surgery, there's no pain. It's not going to hurt. I'm going to talk you through the entire process. You're in good hands. You're constantly reassuring that patient so that they gain that confidence and have a better experience in the operating room.
That is so beautiful. And you're exactly right. And now we have so many different technologies that we can focus on quality of care, quality of life even more. And as I was thinking about what I've done differently in cataract surgery than maybe 10 years ago, like you said, Mark, we're looking at different IOL options. We have so many different options nowadays. Anesthesia is changing, where maybe some of us aren't using IV sedation anymore because that was the most painful part of the procedure. We're looking at back-to-back surgery. That's something that I started during COVID because we didn't know when we would be able to operate again. And we found that the patients just loved getting back to normal activity, normal routine, instead of having so much downtime. We've really focused on non-interventional approaches, like offering them music during the operation, holding their hand. Physical touch is huge for our patients, especially when they do feel so isolated and there's depression running wild. And then we have more options than ever to control pain and inflammation, maybe addressing ocular surface disease in a way that doesn't involve drops. And so some of those things are that proactive mindset that we're talking about tonight. And so, another thing about being proactive in your mindset is being comprehensive in our approach. And why consider a more comprehensive approach? Well, I didn't know this before I started doing MIGS, but 1 in 5 of our patients will have glaucoma. And so when they come in for cataract consultation, 20% of them will either be on a drop, be newly diagnosed with glaucoma, or need further intervention. And most of our patients, fortunately, have mild to moderate disease. We know that drops can hinder refractive outcome. We know that drops can cause pain and irritation and fluctuating vision, and ultimately quality of vision. And I feel like our goals are shifting a little bit in cataract surgery, where more people want to be independent on their glasses. And so, Dr. Parekh, what have you changed in how you approach your cataract patients with glaucoma?
That's a great question, and what a great evening thus far. Many of us trained in fellowships where you sort of do one aspect of the eye, and I did cornea and refractive actually during the height of refractive surgery, and I thought forever I'd be doing LASIK, maybe sutured IOLs, and cornea transplants, as well as tough cases, and that was my fellowship with Mark at the New York Eye and Ear. But when you go to private practice, you got to take care of the whole patient. I think all of us on tonight's call we're a hybrid of surgeons. We take care of people medically, we take care of people surgically in private practice, but most of our focus truly is on that patient. And whereas we may have an academic mindset, we have to be very innovative, and also match our skill set with a better innovation to what the waiting room wants. And I found many, many, many years ago, when it came to glaucoma, which is a harbinger of corneal failure, right? There's no doubt, higher pressures, we'd have to refer to glaucoma. And it's either drops or trabeculectomy or a trab or a valve. And those are the things we didn't like really in residency, right? I think many of us drew ourselves to the front of the eye because we wanted good outcomes and better outcomes. Then when interventional glaucoma came out years ago, and we were one of the very first to do iStent here in Jersey, we found that we could be the bridge towards drops and, end stage glaucoma surgery, where the morbidity, mortality of eye disease is very high. And we found that we have to match what our patients had. So last year and 2 years ago before COVID, 46% of all my cataract procedures, patients had glaucoma. And like you said, most of them lived in mild to moderate. Almost all of them had ocular surface disease. And here it was, where the cornea meets glaucoma in the angle. And I've become a better angle surgeon. And again, we're all ambidextrous by nature of the trade. So for me, I will speak to my coordinator every week about which IOL is going to be an LRI, is going to be, a patient with blended monovision or a patient who may require one of the trifocals or EDOF lenses. Now we talk about what our approach is going to be for glaucoma in these patients. We talk about it in the chair, like Mark was mentioning, that the journey begins in the chair, and see what they want. How are they doing with their drops? Have they had SLT? Have they had an intracameral bimatoprost like Durista? Have they exhausted that? Where do we go next? So we've really embraced not only MIGS during the time of cataract surgery, but also as a standalone, not in a 75-year-old pseudophakic patient only, but also for the 44-year-old patient who doesn't have a cataract yet, but is exhausted, all means of using drops, can't keep up, takes insulin, takes other pills, has an issue with his or her hand, and offering these great technologies. So I think it's a great time in cataract surgery, refractive surgery, but definitely in MIGS, and how all three really mesh together. So I think the role of eye care here in both ophthalmology and optometry is incredibly big. And I think I'm looking forward to the next 10 years. I worry about the payers. I let my billers worry about that. Once they say, Dr. J, go ahead, do this MIGS, do that MIGS at this center and this, and I figure it out. We then have a game plan going to the OR, and afterwards, so rewarding to get patients off maybe one drop, maybe two drops, maybe no drops, but at least now the pressure is better than what it would have been just doing cataract surgery by itself.
Man, Dr. J, you nailed it. You absolutely nailed it. And so that is exactly what this proactive mindset is all about. We're looking at their lifestyle. We're looking at, SLT as first-line therapy. We're looking at other biodegradable implants where we can maybe get them off of drops. And, the beautiful thing about this day and age in glaucoma is that, it's sexy again, right? It's exciting. We can, go to the operating room and look towards treating the angle with cataract surgery. But if we need a little bit more, we also have opportunity in the clinic as well, with newer classes of medications that are more robust and, again, SLT and biodegradable implants. So you absolutely nailed it. And so some of the things that I ask, when I'm approaching glaucoma, are they new to treatment? Are they on medication? What is their tolerance like? Do they have side effects from their medications? How many medications are they on? What's the stage of glaucoma? What's their lens status, like Dr. J suggested? Are they phakic, pseudophakic, in need for cataract surgery? What's their age? What's our IOP goal? Are there other ocular conditions that we have to address? And what is the rate of progression? And so those are all of the things that I'm thinking about with each individual patient because of the opportunity to intervene a little bit earlier now. And so Dr. Feulner, what is your first line of therapy in a newly diagnosed patient with a goal of, say, 20% reduction?
So my first line is SLT for a lot of reasons. One is, if I think about my own lifestyle, having to remember to put something in my eye every day, or the burden of getting to the pharmacy, the expense of it, and obviously all the various side effects. I really would like to relieve the burden on the patient of all of those things. If I can lower their eye pressure with just one treatment, maybe I always explain that we can do this again. It's so gentle that if it works for a year or 5 years, we can always retreat you. I've had tremendous success doing SLTs in patients, and it is variable. Some people don't get any effects. Some people get 1 year. I have some people that get longer. I have 7, 8, 9 years out. I have people that I do, over again, a second time, especially my young people, because it's really almost like a death sentence for the cornea to start them on topical medications when they're young. We know 100% of them are going to end up with lid margin disease. They're going to end up with ocular surface disease, and not just the cornea, but the conjunctiva. So I really, really try to avoid topical medications in young people. And then in older people, you have the reasons to keep them drop free are many of them don't have the dexterity to put the drops in, or they can't remember them. And then the financial burden on people with a fixed income is tremendous. So for me, SLT has been a great first-line therapy. And, I always explain to patients that sometimes, they have two options, either drops or the laser. And, I explain, like Mark said, that it's painless. It's a painless treatment that takes less than a minute. And if it works for them, it can leave them drop free for a shorter or longer period of time. And I give them the pros and cons of both options. They usually say, well, what would you do? And that's pretty easy answer for me. So SLT has been a game changer for first line therapy for me.
Yeah, that's awesome. And, the light trial has been out for a while now. And, that's exactly what Dr. Feulner is talking about, how, we really kind of trended away from drops as first line therapy and suggested, laser as first line therapy because of this trial. And what we found was, SLT versus drops had almost the same effectivity at 36 months. And 74% of patients were drop free at this time frame. And so we know it works and it can be repeated, like Dr. Feulner said. And what I thought was really interesting is that if you look at this study, no SLT patients required glaucoma surgery to lower IOP, where 11% on drops did. And so there is something about stability in IOP that is absolutely so important. And we can't, forget that. And then you think about compliance too. We all know that patients say that they're going to take drops, and it's like going to the dentist, right? You floss the night before and say you floss, right? That's what I do, at least. And so I've heard already tonight, this is what's so fun and engaging about tonight. We're kind of shifting away a little bit from drops. Drops are still awesome, but we have other options. And one of those options is intracameral bimatoprost, which is a biodegradable sustained release, almost like pellet that was designed to last for about 15 weeks. But what's so neat about this sustained release product is that we find in 40% of patients that they get a year benefit out of it. And even at 2 years, 28% still have an IOP reduction than at baseline. And so it works. And so, Dr. J, this question is for you. Oh, this is the video of how it works if you haven't ever done Durysta or bimatoprost. That's it. I like to do it under the microscope because I feel like patients in the slit lamp get really nervous and anxious. So I like to lie them down, but you can do it right in the clinic, which is nice. And so again, Dr. Parekh, where does the use of bimatoprost sustained release fit in your practice?
Well, there's no doubt many of us on the call have an interventional mindset. So for me, an interventional mindset is between drops and a trab or a valve, which I don't do, by the way. I pretty much stay in the first two categories. So an interventional mindset historically has been SLT, like Lisa well mentioned and articulated, and as well as you with the study, and MIGS. And for me, MIGS during the time of cataract surgery and MIGS as a standalone. The third part of the trifecta has been awesome. It's been fantastic. The only FDA-approved device to really help pressure in people with glaucoma, and having an intracameral device with bimatoprost. It's been a game changer for us in the last 2 years. And yeah, the study showed one thing, but in our practice now, up to 85% of patients still have pressure control after 15 months. It's been terrific. And 40% of those patients actually wiped out 2 of their drops. In fact, 2 days ago, on Friday, I had a patient discontinue their Xioptan and their Combigan. Okay, both great medications made by great companies. So there's no doubt that for us, we become more comfortable with using this product. Initially, we didn't know how it was going to fit in the paradigm. It fits in the paradigm of interventional, and truly it does one thing. It helps improve the ocular surface, no doubt. It helps really cannibalize the use of the prostaglandin. But when you keep on doing more and have more patients in the 10th that are getting this, you see the profile changes, your target patient profile changes, It's not just the ocular service patient. It may be a patient who uses a drop or a sample for a couple of weeks. So, you know what, doc, you mentioned that product. I'll get it in my eye. By the way, is it covered? Yeah, it's covered. Okay, I'll give it a try. And now we were telling them when it first came out, 4 to 5 months. Now we are customarily telling our patients in our practice here in Northern New Jersey, this will last at least a year. And that's almost similar to what we say with SLT. Of course, like Lisa said, it may go longer. When they hear that, even 1 year of not using drops, not using a generic or a branded prostaglandin for that matter, reducing the orbitopathy, improving the quality of vision, I mean, it really, really makes a difference. It really falls in that nexus that we called anterior segment. So it's incumbent upon all of us to use an interventional mindset in the practice, because our refractive patients never showed up. I always thought they're going to sue me 2 years later because they never showed up. They come back 5, oh, Dr. J, I love you, but.
Degradable implants, that's a huge topic right now, and we're keeping track of it. So now we get into the nitty gritty, our surgeries. And so I love to break up surgeries, because what if we have people tonight that have never used any type of MIGS device? And so I always like to start off by saying, to get into that MIGS space, just start with one. Yes. Get good at MIGS. And I know, Dr. Lobanoff, you use eye stents a lot. And what kind of patients are you looking for? You're going in for cataract surgery, you're going to use eye stents. Who is that patient?
Well, let me just first go back for a second. I completely agree with you. Start with one. Pick one and get used to it. Start using it on a frequent basis. You're going to surprise yourself. You can do this. For those surgeons who have not put these stents in before, as we believe it is, and humans being the way that they are, it is hard to use drops on a regular basis. And in addition, over time, these medications do some very good things, but they have side effects.
Goniotomy device with Sight Sciences this week. It was really nice. But again, you're removing this trabecular meshwork about, I would say, 70 to 90 degrees, if you can get that. And you can see that nice little strip coming out. We've talked about combination. We saw hydrus just a minute ago, and a lot of docs are dilating the canal so that the hydrus just slips right in. We also have access to eye stents, but also to eye access, which is a little tree-fine instrument that removes little microscopic channels of the trabecular meshwork. So it's just something to keep in mind. So maybe some of the newer users who want to get into more of a cutting technique, there's awesome technology out there. You see that with any type of goniotomy, you will get a little bit more bleeding. And so it's really important to educate your optometrists as well as, the patient, that they may see not as well right after surgery. And so when we're getting into refractive cataract surgery and we want them to see right away, we really think about different devices. We look at safety and we look at efficacy. But this eye access is kind of a neat tool to remove more of the trabecular meshwork without so much bleeding. In my opinion, we still need some more data behind some of these devices. But again, how exciting, once you get good at the angle and you love it. I know, Lisa, you just are so passionate about intervening in the angle with cataract surgery. It's fun and it's challenging and rewarding.
I think that, you were saying, how do we transition people who are a little worried? And there are some really important pearls. One of the things that really helped me was using a hands-free prism. They make these disposable hands-free prism. And the reason is because, you're always like, look to the left, look to the right, you're having them look to the side. But if you're hands-free on your prism, you can just literally tilt their head with your free hand, and you can get that view you want without relying on the patient to keep their head or their eye in a certain position. And you're also not having to worry about dimpling the cornea with the hand that's holding the prism. So it gives you a much better view, a much better control. And, using Helon GV can clear some of that blood away. So if you're doing a combined MIG where you're dilating, you get a little heme on the way out, and then you want to put a hydrus or an eye stent in, You can just put some Helon GV in there and it opens up your view again. And, and the third really important pearl that I found in doing refractive cataract surgery with MIGS is if you're going to do a toric implant, I'll do my MIG at the beginning so that once I put my IOL in position, I'm not turning the head and then going back and removing viscoelastic. The other advantage to doing the MIG in the beginning before cataract removal is it gives you a chance to tamponade the blood, remove the blood. And, in other situations, if you feel like you need a better angle view, you can do the cataract first, then do the MIG. But I think with torics, it's really an advantage to do the MIG first, then take the cataract out. And then, once you have your toric in good position, you're not fiddling around with it at the end when you're trying to remove that viscoelastic or, trying to get through the blood because now you've put this MIG in, you created some heme and you're trying to get it on axis and gives you the whole case to kind of tamponade it. So those are some of the pearls I think that people who are starting out are real advantages for, overcoming some of the concerns that they might have.
Get the hands-free prism. She's 100% correct. It's a game changer. It makes it so much better.
I love
Without
your
a doubt.
tips and tricks. And Dr. J, do you have any tips as we're going through different procedures in the angle, visualization, different combinations that we're seeing tonight?
What I love the last several minutes is this great display of different technologies. And I think in our specialty, what makes it really exciting is the innovation that we have. So I've always said on the podium, I think I said at ACOS 3 years ago, all MIGS matter. As Mark said, once you get used to using one kind of MIGS, learning how to do gonioscopy, intraoperative dynamic gonioscopy is very different than stable gonioscopy at the slit lamp. It's very different. In fact, stable gonioscopy at the slit lamp is really, really boring. But intraoperative, like Lisa said, head position, doing it before the cataract, after the cataract, as a freestanding. I've seen, as I've taught a lot of surgeons and colleagues and friends of mine, they're very heavy-handed on their second hand. Just kiss the cornea, touch the cornea of the gonio prism. Don't do anything else, and you'll get the view. Go in a high mag and go slowly. No one's judging you for time. It's like doing your first cataract. So I think that's really important. Getting that right view. A lot of folks will do 30 degrees of this and 30 degrees of that, or 40 and 20. I do 60 and 0. I just move the patient's head 60 degrees or 55 degrees. And then by putting in my cannula into the intracameral space, I'll use that as a torque of torquing the eye. And I get the view like this within seconds. Once you get the view, go in a high mag, be slow, be deliberate. And if you get heme, as Lisa said, do a visco tamponade, take time and re-engage yourself, and you'll get there. You'll truly get there. But again, I've always said all MIGS matter. I think it's good to be good at trabecular bypass. Hydrus is good. I use a lot more of iStent. In my hands, iStent works out well, but they're both very good technologies. Get facile in the canal, learn how to do a goniotomy. There's so many different goniotomy devices out there. Yes, Night Science came out with Cyan, but KDB, iAccess, they're all very good. We do all of them because every patient's different. That journey is different. Not every angle is incredibly wide. Some of these angles are very, very moderately sized, and you just got to be very, very careful. Some patients may have endothelial debris and may have bad, crappy corneas in the periphery. You just got to be very careful of that because really where everything meets. So I think that's really important. And once you start getting used to doing one and maybe two, then you can start combining things, as you mentioned, Deb. Combining here is very, very important just to make sure that for these moderate patients that may be on 2 or more drops, as long as the insurance pays for it, have the ability to innovate with 2 things. So it's almost like using a prostaglandin in combination therapy, right? A Combigan or a COSOP, the exact same approach. So if we keep on innovating in interventional glaucoma, we will truly, truly halt the progression to an end stage in 5 to 10 years. And I see that now at the visual fields being really stable. Before we thought the disease progressed, you know what? Like Mark said, it wasn't disease. The patient fooled us in compliance. They only complied a few weeks before seeing us, not in between. So it truly is a great, great tool in anterior segment surgery. And I love your next slide, by the way, on standalone. I'll let you have the speech here.
I know, Dr. J.
I get
I'm so
passionate. I get really
passionate
passionate
about it.
this stuff. That looks like teeth, by the way, on the right. What is that?
Oh,
Is it a
I
dental
know.
procedure or what?
It is such a fun procedure, ECP. So I love doing ECP in combination with viscodilation, goniotomy, especially for patients who have already undergone cataract surgery. And even in patients that have had a trabeculectomy, you think MIGS has only been around, for the last, 11, 12 years. And so before that, it was drops, laser, or a trabber tube. And so I have a lot of patients that had a trabeculectomy. That was the only thing back in the day. And their pressure is now going up into the 20s. And so I'm going back to the angle now. And what I like about, viscodilation and goniotomy is you're really expanding Schlemm's canal, opening up those aqueous collector channels, and then removing diseased trabecular meshwork. And I like combining it with ECP to try to get a little bit more bang for my buck. And so again, these combinations can be done. And, insurance is a pain. And I love what you say, Dr. J, about do the right thing. If a patient truly needs an eye stent, do an eye stent. If a patient truly needs removal of trabecular meshwork, do that. I can't stress that enough because things will always change, but do the right thing and really provide that individual care. Am I preaching too much? I'm so passionate about it. But no, it has been such a game changer, and we just showed you multiple different technologies and devices. And, one thing that I wanted to bring up about dilation, viscodilation, sometimes, like you said, we're not starting right off with surgery. Maybe we're starting off with SLT. What do you guys think about, if SLT isn't working, does that make you go towards more of the viscodilation or goniotomy route than just bypassing the trabecular meshwork? How about you, Lisa?
I think it's a complicated question. It has to really be individualized. So you can have patients who have multiple topical allergies, preservatives, and things like that. Or you may have a patient who has, physical restrictions, financial restrictions, mental status restrictions, age. I think I really make my decision based on the whole patient. And you talked about, I think Mark talked about, having the patient sit in the chair and finding out about their lifestyle when you talk to them about cataract surgery. And I make my decisions for my glaucoma treatment based on that whole patient, their social situation, their financial situation, their comorbidities, their mental status. And I think I just really customize it based on what the whole picture looks like, because what's good for one patient, it's just not one fits all. I mean, we really have to work with the patient, sometimes their finances, their family, and figure out what is the best solution that's going to ease the burden and control their disease.
That's right. And that's so right. And, I'll just kind of end with a less invasive, approach before a trabber tube, and that's a Zengel stent. And you can see 3 different videos going right now. Those are 3 different ways I've tried this and, have had success. And so you have your ab interno approach, closed ab externo, and then open conj approach. And so, when the angle fails, we still have tools in our toolkit to be able to get the pressure down into the mid to low teens before maybe going towards more of a trabeculectomy or tube shunt. And again, based on the individual patient. And so we kind of talked about a bunch of different pearls. Dr. Lobanoff gave some wonderful pearls around, refractive cataract surgery and the use of MIGS. And Dr. J and Dr. Feulner have also given just lovely pearls. So I'm going to go to kind of the next slide. Since we're ending our time, which I'm so sad, not only can we be thinking about glaucoma drops as a biodegradable option, but also treating inflammation. And so there's a lot of different ways to decrease the drop use after glaucoma surgery or cataract surgery. This is a little implant put underneath the lip of the anterior capsule. That's dexamethasone. And then we also have intracannulicular dexamethasone available to us now as well, to control inflammation. And that's where you just dilate the punctum and place this little insert. And so kind of the last part of the topic is, can we consider premium IOLs as cataract refractive surgeons in our patients with glaucoma? We have all these beautiful options. What do you guys think? Dr. Lobanoff, in closing, what do you think?
Absolutely. I think these patients deserve a discussion as to what they want their life to be like, what's important to them, and then what are the different ways we have of achieving that. Really, all of the lenses, in my opinion, in the list that you've got here are great choices. And in patients who do start to lose some vision from glaucoma, typically it's more in the periphery, not affecting that central precious vision. And so for the patient population, for the glaucoma patients, I think for the most part, unless there's other pathology, really everything's open to them.
I love that. And Dr. Feulner, any other pearls to consider when you're addressing not only cataract patients, but also cataract with glaucoma?
So, I think that, I think Mark talked and Jay talked about the sustained release medication. And I think in some eyes, in preparation for cataract surgery, especially like Mark said, in patients who are super interested in having, an advanced technology lens with an extended range of vision option, preparing that ocular surface by reducing that drop burden and giving them that sustained intraocular release. I think the discussion gets much more complicated, but patients are more demanding. They expect more. They want that knowledge. They want those options. So I think, I really, give them, the full discussion and what their options are. Sometimes we need to give them a drop vacation to see if they're a candidate for, a advanced technology lens. So I think having that discussion, being straight up with patients when they are and aren't good candidates for an advanced technology lens. I think we need to be very confident in our own decision-making and not let ourselves be forced into something that we don't think is appropriate. But at the same time, for that mild glaucoma patient, and today, what is mild glaucoma? For me, as soon as someone has a visual field change, they're already moderate, because mild glaucoma is diagnosed on OCT changes in both the ganglion cell layer and the nerve fiber. Time. So we're treating glaucoma early. So who has glaucoma? That definition is defined by where science is going. So we should feel more comfortable if we have the discussion about advanced technology lens with a patient that we've treated to lower their pressure for nerve fiber changes, but not necessarily a visual field change. To me, if they have a visual field change, it's not mild anymore. And I'm a little less probably likely to have a discussion about maybe a multifocal EDOF or another advanced technology lens, because you're already into 24 degrees, and so they're a little bit more advanced than I'm comfortable with.
Yeah, that's wonderful.
Yeah, go totally ahead. Right.
I want to do the right thing and, put a lens in that we would put in our own. At giving them the opportunity with their lifestyle of what they desire. And so encounters, we have a great responsibility to continue to push ourselves for our patients, and focusing on a comprehensive and proactive approach will improve quality of life and quality of care. And this was recently in Guatemala. This patient came in, light perception vision in the left eye because of glaucoma. And he was light perception because of cataracts and glaucoma in the right eye. We performed goniotomy with stenting with M6 and MIGS. So that's really an opportunity that we have to take to patients that maybe can't afford care, can't afford medication as well.
Wow. Deborah,
Fantastic.
thank you.
Amazing.
Well done.
Folks, this has been an exceptional episode. Honestly speaking, I learned so much from this. I just wish we had more reach in my country, where I'm from, India, where we can actually reach out to all these mixed procedures. So honestly speaking, everybody who's listening on, we're waiting with eager arms for MIGS to come in and help us as well. But predominantly what you have shown today is mild, moderate, or severe. There are options to a whole new upcoming new technology that's coming for glaucoma. I think the next decade is a MIGS decade, and the kind of stuff that people are talking about, from US to Israel to all the other countries where innovation is happening, it's just brilliant. And you've put such a beautiful presentation together, and excited all of us now towards this glaucoma as a refractive surgeon, cataract surgeon. It's wonderful. I definitely want to thank Mark, Lisa, and Jay for spending time with us. It's been over an hour, but honestly, didn't feel like I felt we could go gone for at least a half an hour more.
Oh, without a doubt, without a doubt.
But all good things, I must say, in this episode. All great. This session. Definitely want to thank Jen, Laura, Bill for helping me through this whole Rising Star season 3. Thank you, audience, really, for patiently listening in and taking part in the discussion as well. I know some of the questions were asked, but they also got answered during the conversation. We're really, really honored and humbled by the support that you guys have shown us. So just a repeat on certain of the housekeeping items, please follow us on social media: Instagram, Facebook, LinkedIn, Twitter. The entire episode, along with all the previous episodes, are on our risingeyestars.com website. So please do go ahead and review it, review it whenever possible. Follow our YouTube. Without any more further ado, good night and good morning from wherever.
You guys.